Good morning, respected teachers, my seniors, my colleague, and my juniors. Today's my topic is lapse and relapse in alcoholic liver disease. So I'm going to discuss this topic under these headings. So the first one is I want to discuss the contribution of alcohol to liver disease burden in India, Asia, and the world. So the first figure, just I want to discuss first. This is the IL-based data. In this, the first figure, it shows that the total number of admitted patient from 2010 to 2021 with cirrhosis, and it found that the most common etiology is alcohol, and that is around the 44%, followed by the NASH. In the figure 2, it shows the data of the total ACLF patient who visited to ILBS from 2010 to 2020. It shows that there is a total of 3,283 patient has diagnosed as a ACLF, and in that the alcoholic hepatitis was found of 63.4%, followed by Delhi. So this figure was published in Lancet in 2019, and it shows the proportion of cirrhosis related death in the Asia Pacific region, and it is found that after hepatitis B, the alcohol is the second most common cause for the cirrhosis related death in the Asia Pacific regions. And this figure was taken from the Lancet, published in 2022, and it shows that there is a premature death due to the liver disease from 2020 to 2050 in the European countries. It shows that alcohol is going to be the most common cause for the premature death due to the liver disease. So natural history and the spectrum of alcohol liver disease. So the individual, those who are taking the heavy alcohol drinking for the longer duration, and those who are having the risk factors like obesity, genetics, smoking, and the associated viral hepatitis B and C. So 90 to 95% patient will develop the steatosis, and out of those who develop the steatosis, 20 to 40% will develop the fibrosis, and only that 8 to 20% will develop the cirrhosis. And after cirrhosis, or sometime without cirrhosis, those who are taking the alcohol, the 3 to 10%, those who develop the cirrhosis will develop into SCC. So I'll focus on the definition now. So what is the relapse? Relapse is a resumption of sustained or harmful drinking pattern after the abstinence. So there is a 3-level definition of relapse. There is a mild relapse, moderate relapse, and the severe relapse. Mild relapse is occasional slips less than once per month, and moderate relapse is continuous drinking at daily and weekly doses within the recommended standard of NIAA. That is 4 drinks per day for men and the 3 drinks per day for women, or less than 14 drinks per week for men and the less than 7 drinks per week for women. And what is severe relapse? It is regular use above the recommended standard of NIA or with associated morbidity and mortality. What is relapse? Any episode of alcohol consumption not classified as relapse is defined as lapse. It is an isolated event. It does not necessarily lead to the full return of heavy use, but it is an opportunity for immediate interventions. Definitions of drink and drinking. So one standard drink is equals to 10 gram of alcohol according to the WHO guidelines. And what is harmful drinking? Where alcohol use is causing damage to either physical or mental health. Heavy alcohol drinking is defined as consumption of more than 60 gram of pure alcohol on one occasion. Binge drinking, consumption within 2 hours of 4 or more drinks for women and the 5 or more drinks for men. How to diagnose alcohol use disorder? According to the DSM-5 criteria, it has 11 points. So if any individual fulfilling the 2 or more criteria occurring within a 12-month period is diagnosed as alcohol use disorder. So alcohol use disorder again graded according to the severity in mild, moderate, and severe. Mild is presence of only 2 to 3 criteria. Moderate is a presence of 4 to 5 criteria, and severe is 6 or more criteria. So, so what is the burden of relapse in ALD care? So, high recurrence rate, 30 to 40% of patients with alcohol-associated hepatitis return to drinking within 1 year post-diagnosis, and it causes healthcare burden because the relapse drives repeated hospitalization for decompensation like ascites, HE, and the varicose bleed, and it causes the mortality impact also. So in this figure, we can see that this is an estimated 5-year survival probability by drinking status. So it is seen that those patients who has sustained abstinence in comparison to those who are having the relapse in the harmful use has more than twofold compared to more than twofold of mortality risk. Post-transplant relapse. This is also important area we have to discuss. So the overall incidence is 20 to 25% of patient at 5-year post-transplant, but harmful or sustained relapse is less than 10 to 15%, and the highest risk in first 1 to 3 year of the post-transplantation. So this and this diagram showing the incidence okay, that 5-year post-transplant follow-up, 20 to 25% have the incidence of relapse, but sustained or harmful is only 10 to 15%. Early liver transplantation for the alcoholic hepatitis. Generally, initially the guidelines was the alcohol abstinence for 6 months is compulsory for the liver transplantation, but is now removed. So, what the early liver transplant for alcoholic hepatitis says, so it says that the slightly higher early relapse rate versus 6-month abstinence cohort, but there's a similar long-term survival. IL-based study. There's a post LT alcohol relapse data is there, and the study is done by the Falari et al. In 2023. That is a single-centered observational study, and the study period was July 2011 to July 2021. There is a total of 720 LDLT was done, and out of that, 28.2% are the etiology is ethanol related, and it was seen that the relapse was found relatively low, that is around 9.85% in medial follow-up of 52 months. The predictors of the relapse in the post-transplant patient, we found that in there is a pre-LT relapse, shorter abstinence, higher alcohol intake, tobacco use, absence of life partner, second-degree donor, or the poor medication compliance. So, determinants of long-term mortality in ALD. So, this figure shows the effect of abstinence during follow-up on survival probability. So, the first figure showing the survival probability in the early or compensated alcoholic liver disease, and the second one in the decompensated alcoholic liver disease. In both the figure, we can see clearly those who have abstinence have a higher survival probability comparison to those who have the continued alcohol. This figure showing the impact of alcohol use disorder treatment on clinical outcome among patients with cirrhosis. So, in this we can see that there's a new hepatic decompensation, 180 days mortality, or the long-term mortality in all three graphs. There is a those who have those who are not any treatment comparison those who are in treatment. So it sees that those who are on any treatment have lesser hepatic decompensation, lesser 180 days mortality rate, and the lesser long-term mortality. And in this study, it also concluded that the only 14% patient received any treatment of alcoholic use disorder. The predictors of the lapse and relapse. The factor contributing to the lapse and relapse. So I divided it into psychosocial factor, biological factor, and the alcohol-related factors. So in the psychosocial factor, the social support, those individuals have the poor social support, or stressors like financial issue, family issues, or mental health. Patient is in anxiety disorder, bipolar disorder. uh, and in the biological factors, genetic predisposition like PNPLA3, TNF, TM6F2, MBOT7, and neurobiology of addiction. And the alcohol related factors, it comes the craving and the withdrawal symptom, and the trigger and temptation like festivals and the some gathering like festivals and some get together. So I want to discuss the neurobiology of alcohol addiction. So in this figure, just I want to just focus that there is a dopaminergic neurons in the ventral tegment area that is project to the nucleus accumbens, and this constitutes the rewards pathway. So what the alcohol is doing? Alcohol cause the
Use your cursor or pointer.
yes, sir. This one, sir, I'm just discussing. What the alcohol cause? Alcohol causes the release of endorphin, which activate the mu opioid receptor. What the mu opioid receptor is doing? It is inhibiting the release of the GABA. And generally, normally the GABA, what is doing? He is inhibiting the release of the dopamine. So if the patient is taking alcohol, it causes more release of the, it is inhibition of the GABA neuron and the more release of the dopamine. So this cause the activation of the dopaminergic reward pathway. So with increasing use, dopaminergic reward pathway is decreasing, and the more alcohol is required to achieve the desired impact, that is leading to the further compulsivity. So Relaspe predictor scores. Two scores, I want to discuss more briefly. That is a SALT score. It detect it predict the post liver transplant sustained alcohol use. So the score has range from 0 to 11. It has a 4 components in SALT score. The first one is more than 10 drinks per day at initial hospitalization, or multiple prior rehabilitation attempts, prior alcohol related legal issues, or prior illicit substance abuse. So those have the score of 5 or more is high risk, and the patient have 25% of risk of the sustained relapse of alcohol. Another score is HALT score. It predicts the harmful alcohol relapse. The component of this score is a history of heavy drinking, that is 10 drinks per day at peak use, prior rehabilitation attempt, less than 6 months of abstinence prior the liver transplant, or diagnosis of any major depression or the bipolar. So the high risk individual are those who have the score of 3 or more. So in this patient there is a 30% risk of harmful relapse. So it has, this score has high specificity for identifying those needing intensive supports. Assessment of assessment related to alcohol use disorder. So I divided it into subjective marker for relapse, subjective marker for craving, alcohol withdrawal, and the objective marker of relapse in blood, urine, and others. So method of assessment: audit score, audit C, 2 questionnaire score, 1 questionnaire, DSM-5 criteria, that is I already discussed in the initial. So what is audit score? It is a screening tool for the alcohol use disorder, and this is a gold standard because it is a good sensitivity and specificity. It contains of 10 question, and each question have a score of 0 to 4. In the question number 1 to 3 explore the consumption, question number 4 to 6 explore dependence, and question number 7 to 10 explore the alcohol related problem. So those who have score of 8 or more indicate hazardous and the harmful alcohol use, and the score of 20 or more they need the evaluation for the alcohol dependence. Single questionnaire score. So in this this is a high this is a sensitivity of 54% and specificity of the 87%, and we ask the only one question: how often do you have 6 or more drinks on one occasions? And the another score is 2 questions score, with sensitivity of 87% and specificity of 80%, and we'll ask as a result of your drinking or drug use, did anything happen in the last year that you wish didn't happen? And the another score is audit C score. This is the first three question of the audit score. It detect the hazardous drinks or have active alcohol use disorder with overall accuracy of 91%. Assessment of craving. For the assessment of craving, there's a pan alcohol craving score. So that is called PAC score. It is a 5-atom unidimensional self-reporting questionnaire. In this, we are assessing for the craving for alcohol, frequency, intensity, and the duration of craving for alcohol. Another score we are commonly use are obsessive compulsive drinking scale. This is a self administrative questionnaire. It will take 5 to 10 minutes with maximum score of 40, and it contain of 14 items, 14 questionnaires. And the other score are alcohol urge questionnaire and the alcohol craving questionnaire. Assessment of alcohol withdrawal. There is a 2 score SIVA AR score. It is a 10-item scale, can be applied bedside by trained nurse, and the score of less than 8 suggestive of no intervention required for the alcohol withdrawal syndrome. And the another score for the alcohol withdrawal is brief alcohol withdrawal scale. Objective marker of relapse. I divided into two parts: indirect marker or the direct marker. So indirect markers are easy and inexpensive, but it has low sensitivity and specificity. And the direct marker like ethyl glucuronate, ethyl sulfate, phosphatidyl ethanol, fatty acid ethyl esterase, it has a high specificity, but there is a various confounding factor may have impact on the results. So in the indirect marker, this I want to focus on the carbohydrate deficient transferrin more, because this is because it has a detection window of 1 to 2 weeks, and the individual has to take around 50 to 80 gram of alcohol per day for at least 1 to 2 weeks for this test to come positive. In the direct marker, we can do with the breath alcohol test, ethanol in the serum, ethyl glucuronate in the urine and the hair. The ethanol concentration in the blood is more than 30 milligram per deciliter is legal alcohol if anyone is with driving, drinking and driving. There is a legal issue can be happen if it is more than this. And the ethyl glucuronate in the urine and the hair. So with the urine, the detection window is up to 40 hours, and the individual has to take at least around 5 gram of alcohol. But it has a confounding factor like accidental contamination of food, mouthwash, or alcohol-free beer. And the ethyl glucuronate in the hair, it has a detection window, is a long detection window of 6 months, but the individual has to take the 20 to 40 gram of alcohol for at least 3 months. In this, the confounding factor is if the patient has a seriously impaired renal function, or the patient ethyl glucuronate containing hair treatment. Just I want to more focus on the phosphatidyl ethanol formation and detection. Generally, the normally the phosphatidyl choline is present in the RBC membrane, and there is a enzyme phospholipase D. So what we'll do, in presence of the alcohol, the phosphatidyl choline converted into phosphatidyl ethylene, that is a more stable metabolite in the RBC that we are detecting in the phosphatidyl ethylene test. So it has a detection window of 2 to 4 weeks, and it is dose dependent. The interpretation for the PET test, generally the less than 20 nanogram per ml is suggestive of the abstinence, 20 to 200 nanogram per ml suggestive of the moderate consumption, and the more than 200 nanogram per ml suggestive of the heavy consumption. What is the advantage? Advantage is it is a superior sensitivity and specificity comparison to the indirect markers, and it is not affected by the liver disease severity or inflammation. And sometimes there is a limitation, or the confounder is the false negativity if the patient has a recent history of the blood transfusion, or the patient is in the dialysis, or a false positive in theoretically in those who have the high hematocrit value. So I'll go on the management of alcohol use disorder. So management cirrhotic patient with alcohol relapse, I'm dividing into two parts: pharmacological and the non-pharmacological. In the pharmacological, I'll focus on the baclofen, naltrexone, acamprosate more, and the others are newer agents as topiramate, gabapentin, and the penicillin. So baclofen, the mechanism of action is GABA B receptor agonist. The initial dose is generally we are starting with the dose of 5 mg thrice daily to the titrate up to the 10 gram orally thrice daily. The side effects are fatigue, sleepiness, dry mouth, decreased appetite, and the headache. I want to just discuss more, focus on the baclofen and the liver function. So baclofen is metabolized only for 15% in the liver, and it is mainly eliminated unmodified by the kidney excretion. There is no hepatic side effect of drug have been reported either in patient with alcohol dependence or the neurological disorder. And this is a hallmark study that is published in the Lancet 2007 that focus on the effectiveness and the safety of baclofen for the maintenance of the alcoholic abstinence in alcohol dependent patient with liver cirrhosis. It is a double blinded randomized controlled study. So in this study it shows that there is a effectiveness of baclofen was specifically evident more in patient with advanced liver cirrhosis in child B and child C. So this figure, Kaplan-Meier figure, shows those patients who are on treatment have the lesser lapse and relapse comparison those who are not on any treatment, and with a significant p-value. Naltrexone. Naltrexone is a opioid receptor antagonist, delta and kappa. The mechanism of action is it reduces the central dopaminergic release via blockage of the opioid receptor, and it reduces rewarding and the pleasurable effect of alcohol. The dose is 50 mg daily orally or 380 mg IM monthly. The common side effects are diarrhea, nausea, somnolence, anorexia, anxiety, and dizziness. And there is a it is more effective in those who have a high level of craving, and those patients has those of family history of the alcoholism, and the presence of specific polymorphism in the opioid receptor gene appears to predictive of positive response. ILBS experience for in the naltrexone safety. There is a retrospective data that is presented in the ASLD 2020 of 86 patient. It shows that the naltrexone is safe and effective. And the another study is double-blinded randomized control study by Dr. Mansha ma'am, and it also shows that naltrexone is safe. My study is on the naltrexone baclofen. My study was the efficacy of baclofen versus naltrexone in achieving and maintaining abstinence in alcohol dependence. The aim of the study was to compare the efficacy of naltrexone versus baclofen in achieving and maintaining 12-week abstinence in patients with alcohol-associated liver cirrhosis with continued alcohol use. So the total sample was 62, 32 in the baclofen arm and 32 in the naltrexone group. So the key finding of the study is the both baclofen and naltrexone are effective in reducing the severity of alcohol dependence. Baclofen shows the greater efficacy in reducing obsessive alcohol related thought, that is craving, and the naltrexone is more effective in controlled compulsive drinking behavior. Acamprosate, the mechanism of action is the glutaminergic antagonist and GABA agonist. The dose is 666 milligram per oral thrice daily, and generally it is avoided in patient who has a severe renal insufficiency, and the most common side effect is diarrhea. Generally, some studies is done in the acamprosate that is given only in the child A and the B group only, and the one issue is the patient has to take the 2 tablets thrice daily, so there's a compliance issues also with this. The newer drugs is topiramate. It is anticonvulsant. The mechanism of action is the glutamate antagonism and the GABA agonist activity. The initial dose is 25 milligram daily, and it should be titrated up to 150 milligram twice daily over several weeks. And the dose reduction is needed if the creatine clearance is less than 70 ml per minute per 1.73 meter square. The issue is that it has liver toxicity because it is metabolized by the cytochrome P3A4, and the side effects are paresthesia, altered taste, anorexia, difficulty in concentration, HE, and metabolic acidosis. Gabapentin. The mechanism of action is it is a calcium channel or GABA neurotransmission modulator. The dose is 300 to 600 orally thrice daily, and the dose adjustment needed with if the individual is having the creatinine clearance of the less than 60 ml per minute. It has mild to moderate reversible cholestatic liver injury, and the side effect is fatigue and the headache. Newer treatment, FMT. So there is a two study. In the first study, there is a randomized control study with the total sample size of 20. It shows those have given the FMT have the significant reduction in the craving comparison to the control arm, that is 90 versus 30%, and there is a lower urinary ethyl glucuron level, and there are improved cognition and the quality of life at 6 months. The next study was a retrospective study of FMT after 3 years. So it shows that there alcohol relapse was lower in the FMT group. Alcohol relapse is lower in the FMT group comparison to the control arm, and in this study it is also found that there is a change in the gut microbiota. So in this we found there is a decrease in the Acinetobacter and the increase in the Bifidobacterium. Another study from the ILBS. This is the study name is fecal microbiota transplant for alcohol use disorder in patient with the cirrhosis. It is a randomized control study by Dr. Srijit. The aim was the study was to assess the efficacy and the safety of FMT in decreasing lapse, relapse, and maintaining alcohol abstinence in EOD in patient with cirrhosis. The sample size was 54, 27 in the both arms, and the result was showing at 3 months 6 patients maintained the abstinence in the FMT arms versus the 0 in the control arm. Non-pharmacological treatment. There are multiple non-pharmacological interventions are there, and the most effective is the cognitive behavioral therapy. So it is find that there is at least usual number of therapy sessions should be delivered at least 4 to 12, and there is a specific technique that is effective in the ALD patient, that is motivational interview, and it works best when it integrated with the medical treatment. And psychosocial intervention for the AOD in ALD. So in poor physical health individual mostly excluded from the usual AOD counseling trial. Most liver treatment center do not have necessary infrastructure and the trained clinical psychologists, and very few literatures. This one is already discussed, sorry.